Hello, ladies and gentlemen. Welcome here once again. So, we started looking at drug interactions, right? Drug interactions, okay? Where last time. So, I gave some different classification of drug interactions, which we say number one was what we call absorptive drug interactions. Number two was simply plasma drug interactions, and the third one being what we call hepatic interactions and then the renal aspects. So, these are different types of drug or classification in regard to drug interaction themselves. So I want to highlight a few things regarding what we call absorptive drug interactions. So when it comes to absorptive drug interactions, here we are talking about the ultimate outcome, basically the effect, the overall effect with this type of interaction is simply the bioavailability of the drug, which of course will be affected, right? So bioavailability of the drug. Now, bioavailability basically is the fraction of the administered drug which is able to reach systemic circulation simply after administration. So how much of the administered drug is able to reach systemic circulation? So that's called bioavailability basically. So there are many factors that of course determines these aspects, as what we call the physical factors to do with the drug formulation, and also of course others to do with what we call other host factors. All right, but in these aspects we are not going to discuss the details part of to do that because we're looking at drug interactions. Now there are one drug of course can limit the rate or the extent. So we're going to be looking at what we call the rate itself, the rate, and also the extent of course of the other drug. Okay, either the rate about how, of course, the time that will take this drug to reach systemic circulation. So we don't worry much about the rate interaction aspect, okay, unless you are treating somebody who's in severe pain and they want to get a quick relief from a pain drug where you have to give, or maybe in the case of severe sepsis where you want to get the drugs in the plasma as soon as, but of course you want to give drug orally, of course. So basically, okay, but in this case, what we concern more is simply what we call the extent itself. Now, when it comes to the rate does not have any effect on the bioavailability of the drug themselves in the plasma circulation, but the extent does. So this one, of course, has got effect. Of course, it does reduce. Okay, it reduces, of course, what we call the fraction of the drug, of course, which is able to reach plasma circulation or for systemic or radical for effect itself, basically. So that's what we are more concerned. So drugs can interact there. One drug, of course, can what you call can simply inhibit, of course, or reduce the extent or by which, of course, the other drug need to be absorbed. So that is what we call absorptive drug interaction. So what are the examples of that type of drugs? There are many types of what we call absorptive drug interactions that I want to highlight here. Okay, so under these aspects we can talk about what we call to do with the gastric, so emptying time. Okay, time that it takes, of course, the content of the stomach to empty, of course. So generally, it's about 20 minutes, okay, normally. But after food, of course, goes to 1 hour to 2 hours. That's the normal gastric emptying time. So there's some things that can delay gastric emptying time. So drugs can interact chemicals, of course, with food or other things themselves in the body. Now, when we come about the absorptive drug interaction, there's, as I said earlier, there's some food that can simply delay the time, of course, the gastric emptying time, thereby allowing, of course, some drugs to stay longer in the stomach. And this is one of the concerns we have with regard to drugs that are unstable with regard to what we call the stomach acid, or the pH of the stomach itself, the stomach, of course, itself. Because when you eat something, you have what we call the gastric secretion from the pancreas, and then the acid is coming, of course, in the stomach. So drugs that are unstable at that pH, low pH, may be degraded or destroyed, of course, after taking with meals. That's why we say some drugs need to be taken on an empty stomach. We're referring to, of course, you take the drug 30 minutes before you eat something. You take the drug first, then you may eat 30 minutes after taking the drug, or you can take the drug 2 hours after food. So that is simply to stop this type of interaction with food. Of course, we're simply trying to concern with regard to what we call some most penicillins. For example, the penicillins, we're talking about for example, drugs like Pen V and also the anti-staph aureus penicillins medication like dicloxacillin. These are unstable when it comes to gastric pH, and also azithromycin. These drugs ought to be taken, of course, on an empty stomach. That's the reason why. But generally, when talking about the drugs themselves now, that is generally come the food aspects and the acid effects on drugs, and that of course can affect, because if these penicillins of course get to be destroyed or inactivated by the acid, you have what you call little or no drug of course in the plasma circulation. That means that of course the extent which of course the bioavailability will be reduced, and thereby you have what you call some low levels or subtherapeutic concentration of drugs in the plasma. So that of course can result to what you call treatment failure. That's why I highlight it's very important that a pharmacist of course is a key person to determine whether the patient will get the best from the drugs prescribed or not. The instructions you give the patient are very cardinal, because they determine whether somebody will get the best from the drugs or not. This is also with regard to applies to some TB medication, that they are of course not stable in the acid. Okay, so now when it comes to the drugs themselves, okay, we're talking about some interactions. There's some class of drugs, okay, whereby the drugs can interact of course in the stomach, forming some complexes. These complexes of course cannot be absorbed because they are large molecules, right? So the other effects of the drug to be absorbed, of course, also the molecular weight is very important. The larger the molecular weight of the drug, the less likely for the drug to be absorbed. So now let's give example, of course, with two important classes of drugs. We have what we call number one, of course, the tetracyclines. Tetracyclines are a good name, and also what we have also fluoroquinolones. Okay, these two type of class of drugs have got really interacting with a number of other drugs. For example, they interact with drugs that contain divalent, tetravalent cations. Okay, tetravalent. So I'm saying divalent and also tetravalent cations. Okay, cations means positive charge, of course. So when we say this one, so what are the divalent examples? Of course, calcium. Calcium, of course, got the charge of 2, means it's a divalent cation. Okay, and for the calcium, of course, also ferrous in the ferrous state, of course, and then there's also ferric, which is of course in the trivalent. But in this case, of course, so we talk about the 2+, which is of course the divalent aspect of ferrous, which is iron. We have of course other drug like magnesium. So in this case, every drug that comes in this formulation, you have got some calcium tablets. Okay, we have what we call magnesium containing antacids, magnesium tricyclate, aluminium, which is of course, aluminium is a trivalent, it's a charge of 3+, so those are trivalent. Aluminium itself, ferric, okay, copper of course 2+. So all these these are called divalent and trivalent cations. These cations I've just listed here, they do interact with what we call fluoroquinolones and tetracyclines in the, of course, in the stomach or in the intestines. Then they form chelates. Chelates, large complexes, of course. These are large molecules which cannot be absorbed. They cannot pass through the lipid bilayer of the membranes. So as a result, co-administration or what you call of fluoroquinolone with calcium containing food or drugs that contain calcium, or magnesium or ferrous sulfate tablets for anemia, this of course will limit the extent of what we call tetracycline or fluoroquinolone bioavailability, that their absorption will be affected. This is what we call the absorptive drug interactions, where drugs themselves interact in the GIT tract, thereby forming large complexes and limiting the absorption of the other drug. That's why. So for this is very important. Now, given these aspects got to other drugs, right? So we can talk about what we call tetracycline, doxycycline. If you're taking doxycycline, you're supposed to take together at the same time with the ferrous sulfate or magnesium tricyclate, or you talk about aluminum acid, or even Gaviscon, which has got calcium, what you call bicarbonate, or what you call bicarbonate, what you call acid type of antacid. So those contain some calcium. Everything that is calcium, including dairy products like chocolates. Sometimes you may be wondering why you go to a pharmacist and then they're dispensing to you doxycycline. They say, please do not use this one with dairy products. Most of foods that we have nowadays on the market contains calcium. So it's quite tricky to say this food. Some people may not be able to understand, to identify that these drugs contain calcium, right? So those type of interaction can limit the extent of what call of tetracycline and fluoroquinolone absorption. This can result into what called treatment failure. The patient is getting the drugs, but there's no improvement because of sub-therapeutic concentration of the drug in the plasma, right? That's so the drug, you don't have enough drug, of course, to go beyond the MIC, which is the minimum inhibitory concentration, all right? The other worry with this type of interactions, okay, is that it's one of the most potentiator of drug-resistant development, because the organism begin to multiply under selective pressure. This brings about what we call some resistance. So it's very important that these things are taken into consideration. So let's understand the absorptive drug interaction. So what is the solution to this type of interaction? Very easy. This type of interaction, basically it's absorptive type of interactions, is very easy to deal with. It's only time spacing. So the only way is simply timing, of course. So usually, ideally, 2 hours in between. So when someone, of course, been prescribed, for example, they're taking ferrous sulfate, maybe for the anemia, and also they have been prescribed maybe a tetracycline, doxycycline for NSTI, or maybe they're getting what we call ciprofloxacin for UTI, okay, or STI or UTIs. And what you can do is that they can get either what we call 2 hours in between. So if they get the doxycycline around 8 hours, they can take, of course, 10 hours or 6 hours the other drug, of course. So that time spacing itself is, of course, to reduce that type of interaction. So that's very important. So that's how you deal with this type of interaction. It's simply timings. And with regard to the first type of drugs I highlighted, those that are unstable in the stomach, where the acid itself come and degrade the drugs, that type, of course, same with meal timing itself. So such drugs might be taken on an empty stomach. And sometimes patients, of course, may feel like some GIT, maybe cramps when they take the drug on empty stomach. You recommend, of course, a light meal. So this is how I define a light meal. A light meal, of course, is any food that you take that has no significant effect on the gastric emptying time. So light meal, of course, can be a snack, okay? A snack, of course, just that, of course, so that at least they won't feel pain when they take that drug, of course, on an empty stomach. So that's other thing that can be helping the patient. But of course, when you're dispensing medications as a pharmacist, you must be able to understand or to know that one, you have to give the drug to the patient so that the patient can get the best. So maximizing the effect of the drug. And the second, of course, you must be having in your mind is basically how to reduce also the adverse effects of the drug for your client. This is what I had today for you guys. See you next time.